Mhm.
I think I'm on it. That thing just bings all the time.
Oh, on
It's,
Discord, yeah, it's ridiculous how much we talk
it's
on there.
lively. So
Literally,
hard to
like
keep up.
I have multiple notifications in the background right now, just pinging on the computer, as
Yeah.
well as my fantasy football one that's also blowing up. So it's been entertaining. So
When's the draft?
currently, it's the weirdest league I've ever been in. Here, I can actually show you because I'm going to share my screen here in a second. Where the hell is?
Like Keeper League? What's it like? What do you?
It's incredibly deep, and you can see it's 8 hours per pick, which is
What?
it's 8 hours per pick because it's a
You're in it now?
yeah. No, I'm going to pick my player after this. I told him I'd have to wait a little bit, so this will be proof that I was actually giving the lecture. I literally just said, "Hey, I got to give a lecture, and then I'll go figure out my pick." But it's an IDP league. It's super flex. It's dynasty. It's really really deep and quite insane. So he gave us all extra time because he knew this was something we couldn't get done really quickly. But like all of these little arrows here, those are all draft picks that have been switched around and traded, and you can trade
Oh,
future first or future rookie drafts. Like it's wild.
holy cow.
This is way more intense than any fantasy football I've ever done before. But it's been really fun because it's been taking. I mean, this started.
Okay, yeah, there. That's what I wanted to see. Wait, you didn't. Oh, okay. Oh no, so it goes by like QB. It's you didn't take Herbert. Wait, did you?
I took Herbert first because it's a super flex league
Oh, okay,
with a
got you.
QB
That makes
premium.
sense.
Yeah,
Yeah,
yeah.
got
So
you.
yeah,
Got you.
Josh Allen. My one buddy didn't realize it was super flex, and he did Chase first. So Allen would have gone first.
Yeah.
So yeah, most of the QBs are already off, and then we're currently in a wicked IDP run right now. So that's why I got to figure out who's been taken overnight while I was sleeping,
That
and
is
who's
goofy.
next. It's wild. It's crazy. So
Miles Garrett. Oh, wait.
wait, oh, I can go back.
I don't get it. So you can pick defense too. Like it's not like a
Yeah, you
team
pick
defense.
defense, and they actually they're the last year the 11th highest scoring player was actually a defensive player. So based on the points in this league, so you can actually they're actually worth quite a lot. That's why there's this
Holy
big game
cow.
right now. Yeah.
Wow.
So yeah, I can't decide if I'm going to try to pick one of the like middling tight ends or go for more IDPs. It's probably going to be IDPs. So
Mm-hmm.
yeah, but I got this pick, and then I got 3 picks up. So I got a little bit of time to figure out what's going on. So anyway, that's what I'll be doing after this, as well as preparing for 2 ADA lectures that I have to do tonight. So it's going to be fun. But I'm pretty sure this is where we left off last time. I checked the video we before I started, but we had gone over most of the more simple kind of trauma cases, and now we're going to move into luxations and avulsions and kind of the treatment thereof. So feel free to, if you have any questions, anything, just yell at me. As far as luxations, the thing we were really concerned about is the adverse outcomes that can occur. It's going to usually be pulpal necrosis, which occurs less often than you would think, unless it's pretty extreme, and then it's almost 100% of the time. So this is one where it's pretty black and white. The other one is resorption. And this is the same thing where it's not that common with the more simple ones, but it's highly, highly common with the more complex ones. So going through them, first would be concussion. This is my cute little kiddo who gave me a nice concussion on my teeth the other day when she was flailing. So I had to put a picture of her in there. She's learning to ski right now, so that's real fun. But with concussions, it's just you hit the tooth. It's not mobile, it's just a little bit tender. The most classic one is a dog or a kid threw their head up and hit me in the face, and now the tooth hurts a little bit. As far as what you got to do, you don't have to splint them. Just take an x-ray at 4 weeks, make sure it still feels cold, and then check it a year. And 99% of the time, these are totally fine. They really don't have any risk of necrosis or resorption. Subluxation, on the other hand, this is probably the most common luxative. Let me phrase that. This is the most common luxative injury that I see. And it's probably the second most common injury I see after complicated crown fractures. And with this one, it's going to be both tender and mobile. So this time it's usually going to be about usually class 2, sometimes class 3, depending on how hard it was hit. You're going to want to splint it for 2 weeks with that nice passive splint, and then follow up at 2 weeks, and then multiple follow-ups after that. So 3-6 years, and then usually yearly, just to kind of monitor these things, make sure that it's not starting to go necrotic or anything like that. Usually there's no treatment needed on these, but you're going to have a higher risk of pulpal necrosis, of staining eventually if it starts to calcify, and resorption is pretty low on these. What I usually see is someone says, "Oh, I bumped my tooth real hard when I was playing baseball when I was 16. I'm now 46 and my tooth is dead." That is something we see very, very commonly, where the people in their like late 30s to early 50s had a trauma when they were a teenager and was fine for all these years. And for some reason, it woke up and now the tooth is either discolored or causing pain. All right. Extrusion. I was actually thinking about this when I went back through it. I don't think I've actually seen a case where it was only extrusion. It was usually a bone fracture or something else with it. But for extrusive cases, it's going to be when the tooth falls incisally. You need to put it back in place, splint it. And in this case, if the apex is closed, you do have to do a root canal because you've severed all of that connection. It's not going to go back. That millimeter is, unless it's, wide open on a kiddo, you can sometimes be okay with it. But on most cases, it's not going to work. High risk of pulpal necrosis, so just do the root canal. The good news is it's a low risk of resorption because with the extrusive forces, it doesn't usually damage the PDL so that cementum and the PDL can stay intact. And as long as you get it back in the spot right away, and usually it's still getting blood flow because it's bleeding as it's, even if it's not in the right position, these really don't resorb too much. All right, lateral luxations. So that was talking about. These are the ones that I see all the time. With this type of thing, it's going to usually be displaced laterally, and most of the time it's going to be lingually because the trauma is going to be coming from this way. You can have it go buccally if it's like a punch from the bottom, and the lower teeth will make it go out the facial, but most of the time it's going to be to the palatal. On these cases, because there is a higher risk of bone fracture, they recommend a longer splinting time of 4 weeks instead of 2 to make sure everything stabilizes. And repositioning is usually fun in that it hurts like hell. It doesn't matter how numb you get these patients, they're already going to be in a lot of pain. And you do have to sometimes push pretty hard to get them back into spot. And if they are outside of the bony housing, like if here's the housing and the tooth is normally here and it's now like this, you almost have any of you had to reposition a patient's jaw who has lockjaw if it's locked open?
Yep.
Yep. You push down first and then go back. Same thing here. You almost have to pull it down and then push it back into the spot because that bone is actually going to catch it in that area. Almost 100% risk of pulpal necrosis and resorption, so you do have to be careful with these. They recommend root canal at 2 weeks to give it time to stabilize. I find that most of the time I can do the root canal the same day I fix everything. And so I think that is because a lot of the people who are working on these teeth aren't comfortable working on mobile teeth necessarily. So by giving it that 2-week time period, you can have a little more stability so the root canal is easier. I work on kids who wiggle all the time, so I'm fine if the tooth's a little bit wiggly when I'm working on it. That doesn't bother me. I get in there right away and I get calcium hydroxide. And on these, I'm going to leave the calcium hydroxide a little bit longer. So I usually will do 6 weeks of calcium hydroxide. I'll see them back anyway at the 4-week mark to remove the splint. And at that point, we'll usually take an x-ray to see how much of the calcium hydroxide is either still there or has been resorbed. If a lot of it has been resorbed, we're going to be planning on that in 2 weeks, rinsing it out and replacing it. And then I'll check those generally every 6 weeks until we see that the calcium hydroxide has not resorbed at all during that time period, after which I know things are generally stable and we can finish it. The longest one that I don't think I have that. I don't have that case because it's at a different office. I had one where the general dentist kind of messed up he's no longer practicing, so it's fine. And it was in California, so that no one knows who this is. They messed up the case. She had an avulsion and a luxation. He put a rigid splint and put the teeth back in and didn't do anything for almost 4 months. And by the time she got into my chair, the avulsion had already started to resorb. The luxation had also started to resorb. Took the splint off, thankfully, and got some mobility. So she didn't end up having ankylosis, which is great. But it took almost 9 months on the tooth that was avulsed until the calcium hydroxide finally stayed in there and I could finally obturate it. And she still has the teeth, so it's good. But that's why the early treatment is so important to do it correctly. And like I was saying, calcium hydroxide is really useful on these cases. So a couple different cases here. The one that I'm showing, this is that motorcycle accident patient I referenced I know it's been a few months, but she was the one who had such a bad accident. She lost her leg, lots of facial trauma in this area. I ended up doing, I think by the time we were all done, I did like 5 through 11 on her because the trauma was so big. But that's why it's important to ask when they come in, how bad was the trauma? Because it gives you an idea of how big of an area it could hit. If the trauma was so bad, she had to amputate a limb, clearly that's a lot of force going through her body. And so it's going to affect more teeth than just, oh, I got hit in the face with a punch or something like that. So why are these? There we go. So that's kind of what they end up looking like by the time we're all done. So 6, 7, I think I did 8 and 9. Yeah, a lot of these teeth ended up needing treatment, unfortunately. So that was kind of the point of that one. And then this was one I went in. I rarely go in on the weekend, but a couple weeks ago, I got a text from one of my best friends. Hey, my patient, guess what did this to this poor 28-year-old? What did I say is the number one cause of trauma? I guarantee you guys will be riding these in LA. Come on.
Lime scooter.
Scooters. There you go. Yep. This one I think was a bird. I don't think we have lime in Reno yet. I think it's just birds. But yeah, alcohol plus scooters is a really bad combo. And as you can see, it was bad. So he ended up coming in. You can see this is a picture we took. This was a few days later. The one I got sent was real bad. But he had laterally luxated 8 lingually and chipped 7 and 9. 7 and 9 were actually okay. And I think the only thing that saved these teeth was that ortho retaining wire. If that wasn't there, I think he would have had a lot more damage to these teeth. But that's what it looks like. He was able to get it mostly back into position. I had to pop it a little bit more. That is 9. You can kind of see how the teeth are looking there. And then what I ended up doing, I've never actually done this before, but because the ortho wire, it actually had a little bit of flexibility to it, and it was still holding on 3 out of the 4 teeth. I positioned the tooth back into place, rebonded the ortho wire, and it actually held in place perfectly. I've never been able to do it where it's just on the lingual, but because he already had it, it worked really nicely, and I didn't have to do anything on the buccal. He then went to his dentist the next day to get those two other fillings, the 7 and 9 repaired and back to the normal size. But as we talked about, I did put Vitribond over the dentin to make sure there wasn't any way for bacteria to get inside there. You want to cover the exposed dentin in this area for sure. Otherwise, you run the risk of pulpal necrosis. So that's what it looked like. The tooth was completely calcified too. And of course, my buddy came in with me on the weekend. So he's standing behind me and I'm having to access through this completely obliterated case. And I was like, oh my God, this is like the worst case scenario that I have this god awful tooth. I was so happy. I dropped right in with an 8. I was like, oh my God, thank you. Because it doesn't always work out that way. These are the teeth that I don't like. The calcified anteriors are no fun. So anyway, okay, intrusive. Any questions on the luxations? Because those are going to be the most common ones that you see. Sweet. All right, intrusion. These.
I got a question.
Go for it.
Do you initiate root canal treatment on all lateral luxations, or are you giving some that are very minutely luxated a chance to maybe revascularize?
Good question. It depends on the movement and what the cone beam looks like. So if I can see that there's a socket and the tooth is way outside of it, then I know it's dead, or it's going to die, or it's going to have issues. If I see the cone beam that it's good, and it really hasn't moved out of the bone, but it's wiggly, then I'm going to splint it and follow up at that 2-week mark, see how we're doing with vitality. If it's still necrotic at the 2-week mark, I'd probably wait until the 4-week mark and then retest and see how their pain level is. If they have any symptoms whatsoever, I would go in at that point.
Okay.
Yeah.
So say something's laterally luxated as well. A dentist wasn't able to reposition the tooth back into the socket, comes to you. What type of time period would you say is one where you probably just would be better off leaving it, and if they need
ortho, 48 hours.
48 hours.
Yep.
Okay. Cool.
Yeah. So that's why most, like, the true emergencies where you do have to come in on the weekend are really bad lateral luxations where you're concerned about bone fracture. The other ones are intrusions, because you need to get in repositioned right away, and avulsions. Everything else, you can usually wait until Monday. I'm not too concerned about complicated crown fractures. You're going to probably do a spec pulpotomy anyway, so you can get a couple millimeters out. It's not a big deal. For luxations, they're going to be sore. Tell them to, take ibuprofen. They'll be fine by Monday. But the other ones, anything where you're worried about resorption or you need to reposition the tooth immediately, that's where you do want to come in on the weekend if possible.
Got it.
Thank you. And this is my first time ever coming in for a trauma case, and it was just because Ben asked me. Otherwise, I would have told them to wait until Monday. They'd be fine for something like this. If it had been avulsed and wasn't properly treated, then I would come in. But very, very rarely, most of the time, it's kind of like I said, he had already been to the ER. He had already been evaluated for everything. He was already on antibiotics. So he had already like tried to reposition the tooth himself. So generally, by the time they get, it's not often that someone crashes a bird scooter right in front of you and you get to fix it right there. It's usually I crashed it at 10 o'clock on a Friday night, slept, woke up, realized I was in pain, went to the emergency room. They stabilized me, said I'm all good. And then Monday, I called your office or called my general dentist, went to see them. They fixed up what they could. And now it's Tuesday and you're finally at my office. That's how it happens 90% of the time. Good question. Any other questions, guys? You know, Johnny doesn't have to be the only one to ask questions. It could be somebody else. I think it's because he's closest to the microphone, so I can hear him the best. But yeah, if anyone else,
they can just write down their questions to me, and I can read them all.
You're the moderator of this Zoom call.
Yeah,
I love it. Perfect. No notes. All right, moving on to intrusion. I don't like intrusion cases. These suck because when you apically displace a tooth like that, getting it back into the right position is very difficult. You're gonna have to stabilize these for longer. And you have 100% chance of pulpal necrosis and resorption because you're crushing everything. You crush the PDL, you crush the apical region. It's just, they're really gnarly to deal with. I actually like these cases less than avulsions because there's usually more complications with them. Like I said, I don't like these. Your treatment is going to 100% depend on the root, whether it's closed or open. So if it is incomplete, you allow it to reposition and then check them after 4 weeks. And if there's no movement after that, it's ortho. If it's complete, as in it's closed, you have to see how bad it is. So if it's only 0 to 3 millimeters incisal to the surrounding teeth, generally they will erupt back into spot, usually. Once again, check after 4 weeks. If it's 3 to 7 millimeters, then you can either do surgical repositioning where you grab it and push it back in, or you can do orthodontics. Or if it's more than 7 millimeters, which isn't, I've never seen one of these, you do have to do it surgically and reposition it. So on all of these cases, you have to do the root canal. And in all of these cases, I'm doing calcium hydroxide and I'm doing it until I see that it's stable because your risk of resorption is so stinking high in these cases. Thankfully, this is probably one of the more rare ones that I have only seen a couple of these, but they're always complicated and they're always a mess. Any questions on intrusion? Here's the other problem with some of these cases. Oh yeah, there's 100 other things to consider. This is a case that I saw, this is like when I first opened my practice. Orthodontist referred him to me, and because it's open and was only like a couple millimeters displaced in and apically, I was like, okay, let's let it re-erupt, see what happens. The problem is he never came back for any of his follow appointments with me. He never came back for any of his follow appointments with the orthodontist. So when I was putting this presentation together, I actually texted Adam. I was like, hey, whatever happened to that patient? And he's like, I don't know. They never came back to see me either. So hopefully the tooth's okay. But this is one of those examples where sometimes less is more because, you know, had I tried to surgically reposition it, it would have been a mess. There's nothing really even to grab onto because the teeth are all so immature. So you can't really splint to baby teeth because they're all so wiggly. It's not going to work. Okay, the big one, avulsions. So if you haven't, I'm sure you guys have this paper somewhere in your classic lit or current lit or whatever. There's 3 papers that they have for the IADT. You have the pediatric trauma, which we're not going to cover today. We have everything we've gone through so far, and then we have avulsions. So it is actually so complicated. It's its own like 40-page paper because these are insane. So the first thing is that phone call and how you handle that. And really, we don't tend to handle this too often. It's usually the general dentist. So this is something you want to teach the general dentist. But the first thing you say is put the tooth back in the socket right now. Doesn't matter if you're squeamish, doesn't matter what it fell into, we can handle it. Put the damn tooth back in the mouth. Then come to the office or the emergency room, but make sure you put the tooth back in the socket. Now you've heard, oh, you could keep it in the mouth or keep it in milk. No, put it back in the socket. Don't know how many times to tell everybody this, put the damn tooth back where it goes. Because if you don't do it, the complication rate is 100%, and they're terrible, terrible complications. The faster you get it back into the spot, the better. I have had to reposition teeth that were put in backwards. I've had to reposition teeth where 8 and 9 were swapped. I don't care. It's back in the mouth and it's getting blood flow to the PDL and it's alive. That's all that matters. And to answer your question, that would be a 48 hours is how long you can reposition a vole's teeth. You can take them back out and put them back into the right spot after that amount of time. Have to ask about tetanus because this time it is a risk, and antibiotics you do want to use in this case because the risk of infection is going to be pretty high. You're not going to be scraping the outside of the teeth or anything like that. So there will be bacteria on the ground. So you do want to give them a coverage with some type of antibiotic. Usually the emergency room will take care of this for you. Okay. And just to show you, I'm not insane about putting the tooth back in the socket. Of the first 5 instructions, 4 of them say, put the tooth back in the mouth. Put the damn tooth back in the mouth. Okay, off my soapbox. For patients, if you guys have any patients or any interactions with sports teams, anything like that, encourage the parents to download this Tooth SOS app. It gives instructions for both the parent as well as you as a professional if you need help or general dentist. It is free. It is from the IADT. It's really useful because it will tell you literally what to do about every step along the way. And so if you're involved in sports at all, that is where most of these things happen. Very useful. As well as this little poster thing tells you what to do if it's broken or knocked out. You can print these out, distribute them to local schools, sports teams, slap your logo on there. It's a good marketing strategy as well. All of this is free, by the way. Okay. How do we treat avulsions? This is where it gets a little bit complicated. So I tried to make it as straightforward as possible, but it really comes down to a few different things. How long was it out of the mouth and dry? And that tells us if the PDL is alive. If it was put into a storage medium, what was the storage medium and for how long? Once again, we're worried about the PDL in this case. And then is the apex closed or is it open? That lets us know what the pulp's going to do. So in general, the most ideal is 15 minutes maximum outside of the mouth, 1 hour maximum inside a storage medium like milk, or 1 millimeter is your open versus closed. So those are your key decision points, those 3 things. All right. As far as viability, there's a bunch of different classifications for these. You have most likely viable, which is the tooth is replanted immediately, less than 15 minutes. This is the best situation by far. Viable but compromised, which it was either kept in a storage medium and the total time is less than an hour. Likely non-viable is either in the medium or out in the air more than 60 minutes. Those PDL cells are going to die. These are the worst cases by far. So for closed apex for your adults, put the damn tooth back in. Clean it, verify it's in the right spot. Once again, it's okay to reposition it within 2 days of the accident. You're usually going to splint it with either ortho wire or nylon fishing line works really well. You can use ribbon. There's a bunch of different things people can use. If it's an alveolar fracture, you want to go 4 weeks. You should also consult an oral surgeon at that point. Make sure they don't need to do any. But usually for the mouth, after talking with Chris, for the stuff that we would see, usually they're not going to have to do plates or anything. That bone is so thin and fragile up here. It's more if it's in the face that they're going to do plates to get everything into the right spot. And then you want to start that root canal within 2 weeks. I do it at the same time. Once again, I'm fine working on mobile teeth. It doesn't bother me at all. But for a lot of people, they want it to be more stable. And so that's where they'll do the 2 weeks. But don't go more than this. You want to get calcium hydroxide in there as soon as possible to lower the risk of resorption. Lots of follow-ups, make sure they're on antibiotics, check the tetanus, blah, blah, blah. You guys are going to get the idea. So splints, as far as the different ones, you can use ortho wire. It's going to be 0.016 of an inch or less. Do not use paper clips. There are 2 reasons. They're way too stiff, and there have been some lawsuits about it, but that's a whole nother can of worms to get into. If that's all you had and it's the end of the world, sure, use paperclip, but they're way too stiff. That's the main problem with it. Fishing line works. And then I wouldn't recommend using fishing line on kids because you can't grab onto it really well because the teeth are still mobile. You don't really want to use any baby teeth for splinting because the mobility on them is going to be too much and it can cause that tooth to be mobile as well. I like using Ribond. It's a great product. It is really expensive. That's the one downside with it. And make sure when you're doing this, you keep the composite and the bonding agents away from that gingiva. We want to protect the PDL at all costs. So you can see on this is that root fracture case from last time. You'll see how on these teeth, kind of like a regular amount of composite, this was the tooth that was fractured. So how I recommend doing it, if it's just have a single tooth that needs to be splinted, Go 2 teeth on either side, ideally. Get those set up, looking perfect, bonded, all ready to go. And then while you are repositioning the one broken tooth or a Vol's tooth or whatever it is into the correct spot, after you've etched and primed it, have your assistant come in and put the composite on there. And you'll see there's a lot more composite on this one, because I'm not too concerned if this guy pops off. I'm really concerned if this one pops off. Okay. And yeah, bond the stable teeth first. Okay, so that was the example there. Any questions about splints? Cool. All right, viable but compromised means it's been in a storage medium. So if there's any contamination, rinse it. If there's stuff in the socket, you're going to rinse that as well. Usually there's some start of a coagulation inside the actual socket, so you want to take it out at that point. Don't push too hard because you don't want to, crush the PDL. Make sure it's in the right spot. This is where you could take a quick cone beam and make sure everything looks good. And same 2-week flexible splint on here, same antibiotics, nothing really bad. Okay, these are where it gets real fun. It's not going to live, that, and it's going to be complicated. So still do everything like normal, put the tooth back in, same splinting. The difference here is how you talk to the patient, because it's going to depend on their age. If it's someone in their 40s or 50s, usually they don't have Vol's teeth. But if they do, it's not too bad. It's kind of like, well, we're going to make this thing an implant and it's going to have resorption. And ideally, it's just going to stay there and not cause any issues. But if it does, we'll take it out and do an implant. If it's a kid, that's where it's a problem. So how the best possible outcome for these patients is ankylosis. They have some root resorption, but it stops. The worst is where it's completely destroyed. You've all seen pictures of that. Those are not good cases. But the goal, no matter what, is to keep the bone, because building bone in this area for an implant is very, very difficult. Go talk to the perio residents downstairs, and they'll tell you they hate doing that. It's very, very difficult to get anything to look good. So the good news is, this is from the IADT, the decision to replant a permanent tooth, even if you know it's dead, even if it's greater than 60 minutes, is almost always the correct decision. I'm going to show you a case at the end here where it was, it's a little ludicrous what they ended up doing, but it worked out. So how do you talk to them? If it's an adult, you're going to say, like I said, we're going to pretty much create an implant. That is your best outcome. We can always extract the tooth later. We had a big, 2-hour trauma meeting in January that I led with my SPEAR group. And we talked a lot about this. And all the surgeons said, yeah, it sucks, but we can get them out. It's not the end of the world. What is impossible is building that bone back. So put the tooth in. It'll at least save the bone. Worst case scenario, they got to get it taken out and it'll be a much better implant site. But make sure that I usually say, we're going to be married for the next year or so, because you're coming back so many times, because it's very difficult you have to make sure you follow these things along. Discoloration is highly likely as well. There can be discrepancies between the gingival margins with that ankylosis as they grow. And pretty much this is my language. I'm going to throw everything I have at this tooth to try and save it, but trauma is highly unpredictable. And then here are the things you can do to help the prognosis. Soft tissue, come back for your follow-ups. Make sure we keep getting these x-rays, blah, blah, blah. You kind of get the idea there. Any questions on closed apex? Cool. All right, open apex. So if it's back in there, if there's back to the mouth, it's pretty easy. Make sure it's in the right position. You can, if it's off a little bit, you can reposition up to 2 days later, use a passive splint, and most of the time these heal no problem. They may look a little bit different radiographically when it's all said and done. The tooth might be a little bit shorter. It might have pulp canal obliteration, but the tooth's still alive. It still works. You don't have to do a root canal. You don't have to. There's no resorption. This is the best scenario, and these are my favorite cases. Usually we just follow them up and don't have to do anything. The one thing is, if it does go necrotic, your risk of resorption is very high and it's very fast in pediatric patients. So this is where follow-ups are incredibly important. Make sure you monitor these. And if you see any sign of resorption, even if it's open, you usually want to start the root canal and get that calcium hydroxide in there as soon as possible to try to save the bone. So if you don't see any revascularization, which is tooth still, either responds to cold or you see that it starts to grow, you can either do a revascularization procedure or root canal immediately, because that's going to help lower that risk of resorption. All right, if it's been in a storage medium and it's open, pretty similar. You're going to rinse it out, make sure it's in the right spot, same splinting, same post-op, and just kind of follow up. The risk of these, I thought I had one more thing, sorry. The risk on these of necrosis is a little bit higher, and so follow-up is going to be more extreme. All right. If it is out of the mouth for more than 60 minutes or in storage medium for 60 minutes, it is still a very useful tooth. The conversation is where it kind of gets a little bit different. Make sure you get it in the right spot, same splinting, everything like that. And ideally, we get ankylosis. And I hear you saying, well, why would you want to ankylose a tooth in a kid? It's because there's no other way to build that bone. So we want to save the bone if at all possible. And you can always take the tooth out later. We'll talk about that in a little bit. How we talk on this one is a little bit different because I don't know what's going to happen. So this is the line that old dentist I used to work with used is my crystal ball is completely cloudy. I can't see the future on these cases. Here's the best case scenario. If it's open apex, tooth grows, you're back to normal. Like I said, I love these cases. It makes me look like a hero. I don't have to do anything. Works out great. Here are sometimes the complications, things to watch out for. It can start to discolor. We may need to do a root canal. We may need to do other procedures. We may need to cut the tooth off. We may need to do something crazy like autotransplantation. We may need to do multiple follow-up. There's a lot of different things that can go on with this. And so that's where you got to follow up the patients. Make sure you talk about the open apex and how we need to complete the growth. And that's when we talk about revascularization is we want this root to be nice and long. I kind of go from there. And then talk to the patients, and mostly their parents, really, about the follow-ups, what to watch out for, and how often you need to see them. This was, as you saw from the previous intrusion patient, sometimes this goes right over their head, and we never see them back again. And those cases are not fun. But the ones where you get to see them back, it is pretty rewarding to see them all go through this. Okay. Here's some more adverse outcomes. And so talk about pulpal necrosis, talk about if it doesn't work, resorption. Then pretty much the final line I use is this is going to be replaced with an implant at some point in their life. So start saving now. An implant in the front is right around $5,000. It's going to get more expensive with time. So figure that for generally, this is controversial because everyone's all over it. But from talking to the surgeons, female patients, you can usually do it at the end of high school. So think 18, 19. Most male patients, they're pushing it out as long as possible. I've heard 25 is ideal, but you can start doing implants on males at 21. Give the patients, give the parents this information so they know what to expect. And they know that this treatment is not forever. This is the warranty is on this is zero. We are doing this strictly to save the bone so that they can have a good looking implant, and make sure you tell them to prepare for it. Any questions on that one? Communication is important. That's the whole reason we started this whole damn me talking thing is me talking about communication, actually. And usually I make the joke, you get an implant as a graduation present. So there you go. Okay. Anesthetics. Usually it's not that painful at the time of the accident to put it back in because they just had a big accident. They're filled with adrenaline. Popping it back in doesn't really hurt that badly. Once they're in the office, you want to get them numb if you have to reposition it, do anything like that, because by then the high of the accident has worn off, and so they're going to be more painful. If you look at all the historical evidence, they say make sure you use carbocaine so you don't have a vasoconstrictor. After all of the stuff they've done, there's pretty much no evidence to support omitting the vasoconstrictor, so I just use it. I don't think it causes an issue based on the studies. It hasn't caused an issue, but you may. If you have a question on your boards, say use one with no vasoconstrictor, because I think there's more historical lit that says that. But yeah, I do recommend using blocks rather than going local. So most of the time you're going to go IO right up here by the nose because you want to get this whole area numb. Sometimes you do have to do a palatal, which is little ouchies for them, but you got to do what you got to do. But you want to do a block rather than local so you get the whole area. And that way, if there is an issue with the vasoconstrictor, it's way up here. It's not next to the tooth. For antibiotics with avulsions, yes. With everything else, you probably don't need to. However, I don't think I've ever actually prescribed an antibiotic for any trauma patient because they always have seen somebody else and they're always on antibiotics beforehand. So, it's if you are the one there. If it's an avulsion, yes. If it's anything else, you tend to not need it. In general, you're going to use amoxicillin. Doxy is pretty useful, actually, because the doxycycline interacts with calcium and actually has some anti-resorptive effects. However, you need to make sure they don't have any more permanent teeth growing. Who cares about the wisdom teeth? So if they're older than 12, you can give them doxy and you're not going to have any tetracycline stains. But that can be a useful one if you're worried about resorption. As far as follow-up, Usually we're going to do clinical and radiographic tests. I think we talked about this last time. I always test 6 through 11 at a minimum, sometimes even farther back. And I have that as a baseline. And every follow-up, I go back and retest 6 through 11, cold, biting, mobility, everything to make sure nothing has changed. And then you're going to want to follow up with x-rays. If you're really concerned about resorption, cone beam is going to be better than PAs, but usually a PA is sufficient to see if anything weird's going on. You're going to want to see them usually at that 2 and 4 week mark, because that's usually when you're going to start to see some of that rapid resorption. If you haven't seen anything at that point, you can usually do 3, 6, and a year, and then follow them up pretty much yearly. You do want to make sure these patients come back. With open apex, with revascularization, you want to see them more often because of that risk of that rapid resorption. So I will sometimes see these patients weekly to make sure that they're okay. And that's why the inflammatory resorption on kids is so fast. And if that's the case, you do have to go in to do the root canal. And then check for ankylosis. Have you guys ever tapped a ankylosed tooth? You know what it sounds like? Take a mirror handle, tap it. It sounds like almost like that. It has this tingy, like metallic sound when you hit it. If there is ankylosis, the treatment is going to depend on the age of the patient. And if they're young, you're going to usually want to get calcium hydroxide in there and hopefully hold on to the tooth. And we'll talk about when you would decoronate it. If they're already grown, just treat it like an implant. And most of the time it works out pretty darn well. But you do have to follow these patients up. This is your open apex patient a lot for a very, very, very long time. Okay. As far as how do we do the root canals on these, if they're closed case, I use calcium hydroxide every single time. It doesn't matter if I know that the root canal is necessary and it's from trauma. I know there's a risk of resorption. Just use calcium hydroxide. It's not the pros of doing it in a single visit are so not worth the risks of absolutely terrible resorption. So just use it every time. Like I was saying, I'll generally do between 4 and 6 weeks between the appointments, taking x-rays to make sure that there's no signs of resorption and make sure the calcium hydroxide is still there. And like I said, my longest treatment time was almost a year on that one patient. Most of them I found are good after 2 changes. Usually you don't see anything after that. And you can do internal bleaching on these cases if you need to, because oftentimes these will be discolored as well. For open apex, you really want to avoid doing treatment on these. As far as calcium hydroxide versus triple antibiotic paste, from what I've seen, calcium hydroxide is fine. Which is great because triple antibiotic paste is hard to keep around. It expires quickly. It has to be compounded. There's double antibiotic paste. There's all sorts of different ones. But the most recent literature that I've been able to find, you guys tell me if there's been anything that's come out recently that says otherwise. Calcium hydroxide isn't that damaging to stem cells, and it works for revascularization. Have you guys seen anything different or heard anything different?
Sounds about right to me.
Okay, cool. As far as the differences for when do you revascularize versus apexifixation versus apexogenesis, I always start by trying to do revascularization. If we still have issues, then I'm going to do a long-term calcium hydroxide to hopefully get it to close. And if that doesn't work, I'll use either like a collar plug or something as an apical barrier and pack either MTA or a BC putty or something as the actual apical fill and then fill it up. Oftentimes, posts are really helpful here because there's a reason this tooth was traumatized in the first place, and there's a high risk of it re-traumatizing after. So I've gone a little bit more away from revascularization and more towards doing some sort of root canal just to help stabilize the tooth, because I had a couple of snap-offs on my revascularization because they still stay pretty skinny there. Long-term calcium hydroxide is necessary for all of these. And then, like I was saying, you can sometimes do an apical barrier. Okay. Here's a fun one. So remember how I said when I was working on this presentation, I had like 16 trauma cases all in a row? Here's some of them. So this was a sad one. You can see the date on this. That was June. Kiddo avulsed 8 and 9. And they are I forgot the Frankel scale, whether 1 or 4 is the worst, but they're definitely the worst on the behavioral skill. Like, cannot work on this kid whatsoever. They're working, it's through the Medicaid provider here, so getting the insurance to pay for anything is a nightmare. I just feel for these poor kids. By the time I saw them, this cone beam was taken in November. That's by the time I finally got to meet the patient. Look at the resorption that's occurred during that time. The teeth were avulsed, they were replaced, and never followed up with. I think they were out of the mouth for more than 60 minutes too, if I remember correctly. So you can see they're not looking good. Here's what they look like when I finally get to see them. So really just spindly, nothing left inside there. So my thought at this point is, okay, let's at least get calcium hydroxide in there, see if we can get these things stable. Oh, they were in a rigid splint for that whole time too, which isn't good. It's a mess of a case. And I just got involved recently, unfortunately. So saw them in November and we had to wait for the insurance to even approve it. By the time they got in, the teeth had become even worse looking and the kid wouldn't sit still, wouldn't do anything. And the thought of having to like get an anesthesiologist to come in just for me to open them and put calcium hydroxide in really wasn't an option. So, and here's what they looked like most recently. So what we decided to do, I worked with the pediatric dentist on this one, is the pediatric dentist was able to sedate the kiddo and get the teeth out. Now, this is a 9-year-old. That sounds terrible, but look at what they have coming in. So in a couple of years, we will be doing a lovely auto transplantation of those second buys into that spot once the teeth are in the mouth. And ideally, everything should heal up. I'll show you a case that was done by somebody else. I don't have any pictures from the ones that I've done because it was all a while ago at different offices, but it is a cool case that you can do. Here's another one of some, you can see
time elapsed.
Yeah.
Dr. Sheeter, how much time elapsed before those were planted and then the resorption?
So the initial injury occurred in June. I believe that was more than an hour out of the mouth, was replanted, a splint was placed. They did not get into my office until November. So during that time, nothing occurred. The splint was on for that entire time. These teeth were class 3 mobile the entire time. And I wasn't able to do treatment that day because of dumb insurance issues and 1,000 other reasons, and the kid needed sedation. And I wasn't able to get them in or approved until January. By that point, the teeth looked like this. Oof. And the kid wouldn't even let me put topical in the mouth, even with 0.5 of triazolam on. Just a tiny little girl. Like she weighs like 60 pounds sopping wet. And she was wide awake and screaming when I went in with a Q-tip. I'm like, okay, this isn't going to work. So sometimes cases aren't ideal. My thought, and talking with the pediatric dentist, he was able to sedate her. They just do a couple quick Versed puffs up the nose and they're down, and get the teeth out at least so that they're not hurting anymore. And then when we see her for the auto transplantation, I got a couple dental anesthesiologist friends who will help me out with that one and put her all the way out for that. So she'll be completely asleep, which will allow me to extract the teeth and put them in the right spot.
How are you going to prepare the sites for 8 and 9?
The burr.
Sure.
Yep. Drill a hole.
Yeah. Wow. That'll be cool.
Yeah, I got to talk with. There's a lab tech at one of the offices I work with who's incredibly talented. He's actually going to be doing. I'm going to get expansion done on my upper jaw, and we're going to make a bunch of cuts in the bone and put a bunch of extra bone in there and move it forward. But my teeth are so stupidly long. My canines are 35 millimeters long. My laterals are 26, just to give you an idea. I have stupidly long teeth. The periodontist is a little concerned about that. So he's going to actually have this guy make a stent for where the cuts need to go, which will be pretty sick. And I'm going to see if he could make me, like, off of the DICOM file, if he could make me like plastic versions of what 20 and 29 look like. And that way I can kind of test fit in the plastic ones at the site, leaving the teeth down here for as long as possible and know that everything's going to fit. So that way the time that they are out of being in like a bloody area is going to be, I don't know, 5 seconds. Take the tooth out and immediately pop it back into the right spot, not have to do any adjustments. So I think I can get him to do that. But we got a couple of years until these teeth are in the right spot anyway. So yeah, kind of cool case. That one I'll definitely take lots of pictures and videos on. Yeah. More trauma cases, just a luxation on this one, but same thing. This was one where it had happened a long time ago, started to get necrotic, so you can see the discoloration. Here's another one, spectral-potomy. I think there's a video on that one. Another solid one. I usually don't see it on the mandible, but this was a weird case. Took a while for this one to heal up, but you can see the outcome on that one. More trauma cases here, real fun. This is a retreat where the trauma had originally occurred and redid those. But the point here is 90% of the time, I don't actually have to do the root canal. So with most trauma, you don't usually have to do the root canal. Put that at the very back of your mind. Keep the tooth alive as long as possible. Of all the cases, 50% of them are 8 and 9. 100%. Like, it's just ridiculous how often it's those two teeth. I was so impressed going back through my 8 and 9 cases. And sorry, let me phrase that. all the cases I do that are on 8 and 9, half of those are trauma related. Like, it's ridiculous how much those two front teeth get hit. And so that's going to be mostly what you see of those. The other thing to remember is most cases are going to have multiple types of trauma with them. It's not going to be someone walks in just with a single luxation. Like that kid I saw a couple of weeks ago. Yeah, he had a luxation, but he also had 2 uncomplicated crown fractures. So there's always different things that need to be considered here. So what do you do when things go wrong? Save the bone. So decoordination, if you haven't read, do you guys have this book? It's probably somewhere in that library. It's chapter, I had it out this morning, 31. Chapter 31 is written by my good friend Jared, who I worked with since 2014 on decoordination, but it's called the buck flapless decoordination technique. Works really well, and you want to do it once there's a millimeter in discrepancy between the 2 teeth. How you do it is you don't even have to do a flap. You cut off the crown, taking away, make sure there's no enamel left, keep it intact because it actually works really well as a temporary to make the tooth, because it's there too, so it looks good. You need to remove all the filling material inside the tooth, whatever's inside there, whether it's calcium hydroxide, gutta percha, MTA, whatever it is. Usually you can use really long gates or Munspers. Just drill down it, like it's just go to town on it. You just need the root to be hollow inside there. You want to have blood come through it, suture it closed. And what it does is it keeps the bone in that area. So here's, like I said, there's good old Jared Buck, my good friend who I've worked with for a long time. And this is the idea that after the ankylosis starts, what you're going to do is cut off right here below the enamel layer, leave this bone, and what will or leave this root. And what will happen is this will slowly start to resorb. But more importantly, as the teeth move, this will keep that area. If you just extracted it, what would happen is the bone would stay down low and you'd have this big discrepancy. So cool case. Have you guys done any of these? I did a couple in residency with the ortho department.
Art did one.
Okay. Yeah. So keep it in the back of your mind. It's very simple to do. It's not a hard procedure. It feels very weird to take like a giant ass like diamond burr and just go to town through, like you're literally perforating. Like all the stuff you're not supposed to do is what you do on these cases. It's kind of wild to think like, wait, did I just take a gates like 20 millimeters down? Like this is insane. And did I just cut off all of this tooth in one go? That's insane. But it's a really good procedure that you can do and helps a ton of people. This is another one where the conversation is very important. We're doing this because they're going to get an implant here. Start saving now. People can save up for a $5,000 expense if it's 10 years down the line. It's tough when it's, I need $5,000 right now. Okay, auto transplantation. Like I said, I don't have any photos of the ones that I've done, but I'll kind of show you a couple different ones. You need to have an open apex lower premolar that's in the mouth. That's the problem with that kiddo. She's only 9, so she still has her primary molars. Once they're in the mouth, that's when we can take them out and move them. Ideally, it's going to be one of the lower premolars because the shape of it is close to the shape of what 8 and 9 would be. You can use second buys. You cannot use first buys because of the 2 roots, obviously. What you're going to do is create your socket, replant the tooth, and you want it to be pretty apical. I'll show you a case here that I found from one of the Spear lectures where it's way farther down than you think, but you actually want it like that because the bone will grow and it'll erupt into the site naturally. You only need to put about 3 to 4 millimeters of the root into the bone. So it's not like you're drilling a 15 millimeter site. You only have to go in a little bit and it will grow the bone really nicely. You do need to have a good support team. So you need to have a pediatric dentist on board. Oftentimes you'll have to get them sedated. Some people who aren't comfortable with extractions will need an oral surgeon or a periodontist to do that for them. So this is where it gets a little bit more complicated, but that's where you need to take the PAs of those lower teeth and make sure they're there and that they're a good shape for it. So a couple of the Spear cases, we have a few minutes left, so I'll show you these wild things that they did. How would you guys do this? So they subluxated 7 and 9 during a ski accident. They avulsed number 9. Sorry, that should say number 8. And they couldn't find it. Her friends went back and found it in the snow 2 days later. So she came in with the tooth. What would you do? Rohan, you're closest to the mic, right? I'm not going to do Johnny every time.
You pull out the buck flapless.
You could probably do section off the crown portion of the tooth they found, and you can use this as a temporary.
Yeah. So they did something insane and they put it back in. So it's definitely more than 60 minutes dry because it's been 48 hours. So in this case, they scraped off all the PDL. There is an old technique where you soak it in sodium fluoride. And for this case, you would want to do that. But that helps lower the risk of resorption a little bit. And you're going to leave them in the splint and give them antibiotics. And that's what it looks like. So they did the root canal, and they did the root canal outside of the mouth, which, makes sense because it's in your hand. Why not? And this was done a while ago. So that splint's way too strong. That's way too heavy of a splint. You'd want to go lighter than that. But what's crazy is there's your 5-year follow-up. And there's a 12-year follow-up on that tooth. Is that wild? It's still there. So that just goes to show you, if you have the tooth, put it back in. It can still be useful. No one thought that a 2-year, I didn't think a 1-year follow-up was going to be available on this, much less 12. Here's another insane one. Yeah, 8-year-old, and that's what happens. Everything comes with it. So, and it's been more than 60 minutes outside. So on this case, they end up auto transplanting. And this is what it looks like. So you can see the teeth are actually below the gum level here. And that's all you need to put in. These actually, did I put the post-op? Damn it. Sorry. I'll text you guys it. There is a post-op showing that these teeth were in the right spot eventually and look amazing. It's really cool. So that's kind of the auto transplantation side of it. So let's go to our conclusions. Trauma cases are different because they're really hard. But most importantly, put the damn tooth back in the mouth. Doesn't matter how long it's been out. It doesn't matter what it's been in. Put the tooth in the mouth. It's always going to be the right option. And make sure if you get that phone call, doesn't matter who, if it's a squeamish parent, ask if anyone else will do it. I don't care. Get the tooth in the mouth. Make sure you do your clinical exams. There are legal implications. There's a lot of different treatment options, which means there's no clear flow chart. So this is where we are probably the best ones at this besides the pediatric dentists. And follow up. In terms of your order, you want to save the pulp first. If you can't save the pulp, save the tooth. If you can't save the tooth, save the bone. The research is always changing. There have been 2 different new updates since I graduated, and that was in 2014. So they come out usually every 5 years. I think there's one in 2015 or 16, and the most recent was 2021 or 22. So, and then make sure you guys realize you're never going to make money on trauma. Trauma is a money loser every single time, but it's worth it to help save these people's smiles because no one else is going to do it for them. Okay. How are we all doing?
Good.
Cool. I can't believe we made it through trauma. I was like, I don't think we're going to make it through this today, but we did it. I'm proud of all of you. Will I see you guys? I think I see you guys at AE before I actually talk next, right? Any topics you want to lecture on? Second years. I think I only got like 2 more with you.
Oh, God.
Because I think the June one, you guys might be gone by the last.
Well, I mean, we're here till the end of June.
The end of June?
Till the butt end of June.
I was so surprised. I think the 30th was a Monday, and Hatton was like, "What do you mean? Yeah, you're working." He was, yeah. So it'd be the it'd be the 26th of June. So I'm not sure if I'll talk to you guys then or not, but we got 2 more. So you got 2 more times to hear me babble for an hour. And text me if you have any thing you'd like to talk about. Any other questions?
You at school till the 30th?
No. We had the graduation on the 28th on that Saturday. And he's like, yeah, you guys don't have to come in.
Oh, nice.
So he does have a soft side deep down.
Oh, he does.
Oh, yeah. Oh, I'm actually, so speaking of that, he's not going to be at the AAE. So he told me that I have to represent SLU at the thing. So I need to.
Don't you have to put the dinner thing together?
Oh, it's already done. Yeah, they're already done. I literally just have to show up and shake hands, which
nice.
I don't like doing, but that's a different story. Yeah. So
yeah.
Cool. Well, we'll see you guys there. If you think of anything you want me to talk on, let me know. Otherwise, I'll make something up.
Sounds good. Thanks.
Cool.
God.
Thanks, guys. Bye.
Cool beans.